ahead and get started. So I am very happy to have you at Grand Rounds. I just have to get one other thing organized here, which I have. So those of you who are general internists know that I love at the head of meetings to talk about some meteorological event. So I am just going to say welcome to the first significant snow, which was last night. And I think a lot of people are late for that, so hopefully more people will filter in. And I want to say I am very honored today to have one of our tenured women faculty presenting Grand Rounds. This is Dr. Sharon Hansen, and the title of her talk is Clinical Challenges in Osteoporosis Care, a Case-Based Interactive Grand Rounds. And this gives me a little bit of a chance to brag. The Division of Rheumatology has by far the highest percentage of tenure-track women professors. We just found out Friday that Dr. Christy Bartels has also been tenured, which is fantastic. Yay. So back to Dr. Sharon Hansen. So Dr. Hansen, many of you have known for many years. She did do her medical school here at University of Wisconsin, followed by her residency and chief residency. She went on and did her fellowship at Duke University Medical Center. And interestingly, I forgot about this, she did practice after her residency in private practice in Colorado for a couple years before coming back to join us here at University of Wisconsin in 2001. She also has done her master's here in clinical investigation. She is an incredible researcher for us. She has six active grants. She has an R01 under review. She has over 60 peer-reviewed articles, 4 book chapters. She has done over 16 national and international presentations. And her group of medical students and fellows that she has mentored, which numbers over 15, is quite impressive, and they've been highly productive in the work that they've done in the research arena. Many of you might know, as her Grand Rounds talks about today, that her clinical area of expertise is osteoporosis, but I think many of you also know that she is a coveted rheumatologist here at UW Health. And in fact, her most recent award was the UW Health Patient Experience Physician Championship Award, which she received in 2015, which goes to the top 6.5% of all physicians at UW Health for their care of patients and patient satisfaction. So Sharon just told me what her most coveted highlight in her career is, and so I'm going to pull that out of her CV. And that was in her article in JAMA Internal Medicine, which was her randomized, double-blind, placebo-controlled trial on the treatment of vitamin D insufficiency and osteoporosis. And that was highlighted in the Annals of Internal Medicine as one of the top 7 women's studies for 2015. So that was fantastic. Sharon, we're very happy and honored to have you here, so please come forward.
Betsy, that's a very gracious introduction, and Betsy was my chief, and so I'm just really pleased that she's heading up our Department of Department of Medicine right now. So to prepare for this talk, I spoke to my friends and colleagues and really picked out some cases that I thought would be common things that we encounter in clinic. So really this is supposed to be a case-based, interactive type of Grand Rounds. And I have some patients that I'm presenting. Most of them are factitious. I actually have one real patient, but she's de-identified, so you won't be able to tell who she is. Learning objectives. So we'll talk about some limitations of FRAX. We'll talk about this whole issue of a drug holiday, who is eligible, who isn't. And then I want to touch on the difference between glucocorticoid-induced osteoporosis and age-related osteoporosis, because there's a lot of maybe misunderstanding about the difference between those two conditions. And then finally, I'll hit on a case of renal osteodystrophy and cover that as well. So I hope everybody in the room will have something that they really take away from this as they can apply to their own clinical practice. First, just an overview. So sorry to tell the residents that it's a downhill slide from here on out. So you're actually reaching your peak bone mass right around the age of 30, men higher than women, and then after 30, we all lose a little mineral from our skeleton every year. And then for women, at the time of menopause, we have a fairly rapid additional loss of mineral from the skeleton. We used to think that this was varied by ethnicity and race, but a recent study actually says it actually varies by weight. And if you control for body weight, there's really no difference in the racial drop in bone density in the menopausal transition, but skinnier women lose more bone than heavier women. So, if we think about the prevalence of osteoporosis, once we hit the age of 50, 1 in 2 women and 1 in 5 men will sustain an osteoporotic fracture in remaining life. So every one of you are going to care for patients who have osteoporosis. Compression fractures are the most common type of fracture, and keep in mind that 2 out of 3 of these compression fractures causes no pain. So patients might have some height loss, but that would be the only sign. And that's why we're doing routine vertebral fracture assessment when we do bone density here at UW. Now, when people fracture, they can get chronic pain, disability, and lower quality of life, but also, specifically after hip fractures, but also other fractures, lifespan is shortened. And the most affected are men who have a hip fracture. Their mortality can approach 1 in 3 in the next year. So how are we doing with screening for osteoporosis? And this is just 3 different studies that looked at women age 65 and older who are enrolled in Medicare. And you recall that at the Medicare first visit, a DEXA is actually recommended as part of that first visit in Medicare. So back in the early 200s, we were less than 10%. In the mid-2000s, we got up to about 40%, and now we're just under 50%. If you think about it, really we should be getting closer to 80%. So we can do a better job at screening for osteoporosis. One of the frustrations that I have is that there is no universal screening that's covered for men, but if you indicate that the patient has had a fracture, height loss, kyphosis, or has a risk factor for osteoporosis like prednisone use, you can get the DEXA covered that way. So now how are we doing after somebody breaks their hip? This is kind of the classic presentation of osteoporosis, and really it's outrageously horrible. So back in 2001, we were treating only about 40% of I'm sorry, I think that's 20%. No, it's 40% after they broke their hip. Now look at what happened. So move up to 2011, we were only treating about 20% of individuals after they broke their hip. So this was a call out, a cry of distress that we were missing the boat with these patients who presented us with a hip fracture as the sign of osteoporosis. We weren't even recognizing it or treating it. Now this is a more recent study, and we're doing even worse. So this is from 2004 to 2015, and look, it's about 3% of patients getting treated after they break their hip. So we can do better. Now, the good news is that a lot of organizations, including our own, have developed a fracture liaison service, and we have the person who runs the fracture liaison service in the hospital. Do you want to stand up and say your name, Kristen? So, Kristen Hart. So I want to show the slide that she presented at a meeting. And this is looking at how we did before and after Kristen Hart came. So before is the blue and after is the red. So you see that after fragility fracture, so I missed a joke there, we weren't measuring vitamin D very much. We weren't measuring bone density, and we weren't treating. And thanks to Kristen, we are doing much better with treating patients who present to our hospital with a fragility fracture. So that gives you kind of an introduction as to the prevalence, the screening, the treatment of osteoporosis as it stands today. Now I'd like to move over to this wonderful tool that we've had since the early 2000s called the Fracture Risk Assessment Tool, or FRAX. And I'd like to introduce to you some ideas about the good, the bad, and the ugly of the FRAX tool. So first, this is just a patient that I kind of met radiographically when I was reading bone densities about a month ago. So she's Laverne. She is 64. She's African American, and she's got a low body weight. Oops. And so if we look at her T-score in the spine, it's minus 1.7, so she's got osteopenia there, minus 1.9 at the hip, but over at the radius, it's minus 2.8, so okay, she has osteoporosis. But when we calculated out her FRAX score, it's really low, 3.5% risk of a major osteoporotic fracture in the next decade. So I just want to talk about the FRAX tool and what's good about it, what's bad about it, and what's absolutely horrible about it. So the good thing is it was created based on a series of about 11 cohort studies. So these are longitudinal prospective cohort studies designed to identify risk factors for osteoporotic fracture. The first cohort that was used comprised about 60,000 people, and then once they made the equations, they validated them in another 230,000 people. It's nice because it incorporates multiple risk factors for fracture, and you can calculate out the 10-year probability of a fragility fracture without a bone density test. So it might even be used to decide whether you want to order a bone density test in somebody who you're kind of on the fence about whether to get that test or not. Well, what's the bad? So it turns out the cohort data really underrepresented men. So the question is, does it work as well for men as it does for women? Some of these cohort studies did not look at spine x-rays to find those silent compression fractures. So the concern is it may underestimate the chance of a silent compression fracture. It completely ignores falls. And we know that almost every osteoporotic fracture happens from a fall. So that is a huge problem, and when you use the FRAX tool in somebody who's falling often, you really have to think in your mind, adjust this number upward. Another horrible thing is it only counts fracture as a dichotomous variable, yes or no. So let's say you're meeting somebody who's had a hip fracture and 3 compression fractures. You're just going to write a yes in that box, and you can't write the number of fractures. Clearly that patient's going to be at higher risk than somebody who's just had an ankle fracture. Now, what if your patient has had their hips replaced? You really can't enter bone density at another site like the spine or radius. And another problem is that if a patient has ever been on steroids, this counts as a yes in the tool, and I'll show you some data later that I think that's a flaw and not exactly true. Finally, we are not to use FRAX when a patient is on therapy. It's not been validated in that circumstance. And really the ugly. So going back to our patient, Laverne, she has osteoporosis, but her FRAX score is 3.5%. So I mean, this is a highlight of how somebody can be told that they have osteoporosis, but the truth of the matter is maybe they don't need to be treated at all because their risk of fracture is very low. So in those circumstances, you have to use your clinical judgment and then elicit patient preferences on what to do for that individual. This is just a quick study looking at how FRAX prediction compared with more of a clinical judgment situation. So this was a study looking at over 6,000 women who had low bone density, a third of whom had a compression fracture on x-rays of the spine. And it turned out that the combination of a compression fracture, the femoral neck bone density, and age were better predictors of fracture, a new fracture, than the FRAX tool, including the bone density. So again, FRAX ain't perfect. Just bear in mind the limitations of FRAX when you're using it in clinic. So going back to Laverne, I mean, really, she has a very high chance of not fracturing. I would argue that she's a lady that we don't want to treat because her chance of fracture in the next 10 years is so low. So that was the FRAX. I'd like to move over to drug holidays. So I'd like you to meet Mrs. Smith. She's 65 and has a Welcome to Medicare bone density test. She has osteoporosis, and her FRAX score is accordingly indicating that she would benefit from treatment. So she takes alendronate for 5 years, and she comes back to you to say, well, do I need to continue this drug, or can I take a drug holiday? So just quickly going through the fracture intervention trial extension, which was called FLEX. So FLEX was designed to compare the risk and benefit ratio of continuing alendronate for 5 years and then no treatment, or 10 years straight. And this was a randomized, double-blind, placebo-controlled trial, and it included about 1,000 women who were participants in the fracture intervention trial, took alendronate for about 5 years, had to have a hip T-score above minus 3.5, and had to have better bone density in the hip or stable bone density compared to the baseline bone density before they started alendronate. So these women were in their 70s with kind of a lower BMI compared to what we often see in clinic, mostly white, and a third had a prior compression fracture. So they're randomized to, they've already taken 5 years of alendronate, they're randomized to 5 more years of either placebo or 2 different doses of alendronate. And this is just to highlight the changes in bone density. So what you'll see is during alendronate, the bone density goes up at all skeletal sites. And then this is in the extension trial, and the placebo arm is shown in the open circles. So in the placebo arm, you see a little dip in bone density when alendronate is discontinued. But this is really the meat or the heart of the matter, what happened to fractures. Bottom line, no difference in radiographic spine fractures or clinical non-spine fractures, whether women took 5 or 10 years of alendronate. So that's very exciting. And similarly, the makers of zoledronic acid or zoledronate did a extension trial. In the first trial, these approximately 8,000 postmenopausal women with osteoporosis took zoledronate for 3 years or placebo for 3 years IV. And then at the end of that, they invited women in the zoledronate arm to continue another 3 doses of zoledronate or 3 years of placebo. And bottom line is no difference in the 9 spine fractures, whether 6 years of zoledronate or 3 years and then nothing. Little difference in spine fractures. So what you see here is only 3% of women had a new spine fracture if they got 6 doses of zoledronate, and double the risk, but absolute numbers are very small. 6% had new spine fractures if they got zoledronate for 3 years. So really thinking about whether you want to continue zoledronate, consider if that patient is at high risk for spine fractures because they've had prior spine fractures, they're on prednisone, or their T-score at the spine is low. So now we've got this exciting idea about a drug holiday from alendronate or zoledronate, but we have a post-hoc analysis that kind of refines this idea for us and gives us a little bit more nuanced approach to who might be eligible for a holiday. So I like this because they divided the data into individuals who had no prior vertebral fracture or did have one. And then they looked at the T-score at the femoral neck. So actually, if you had no prior vertebral fracture but your femoral neck T-score is still showing osteoporosis, number needed to treat to prevent 1 new painful vertebral fracture is only 24. So those would be people you would really want to continue treatment for. And likewise, if they've had a prior vertebral fracture and their femoral neck T-score is -2 or lower, then only 17 people needed to treat to prevent 1 painful vertebral fracture. So that gives us a little nuance as to how to use this in clinical practice. So going back to our patient, we have a few questions that I like to ask when I think about a drug holiday in a patient. Number 1, how long did that patient take the osteoporosis medicine, and was that person adherent to therapy? Did that person sustain a fragility fracture of the spine or hip before or during that drug prescription? What happened to the bone density? Did it go down? That would be concerning and indicate I would not be too keen about starting a drug holiday. Does the patient still have a T-score of -2.5 or lower? Does this patient still have osteoporosis by DEXA? Does the patient have an ongoing risk factor for bone loss? And I picked some highlights: prednisone use, weight loss, active cancer, and how often does the patient fall? So going back to our patient, Mrs. Smith, she had the bone density showing osteoporosis. She took 5 years of alendronate, she comes in to discuss the drug holiday. So we ask her these questions. Was she adherent to alendronate? She took it faithfully. She waited a whole hour before she would eat after her weekly dose. She hasn't had a fragility fracture before or during therapy. Her bone density increased while on alendronate. Her T-score at the femoral neck is now osteopenic. She doesn't have any of these ongoing risk factors for bone loss, and she doesn't fall. So if we go back to this number needed to treat, she falls into the category of over 100 people needed to treat to prevent one painful compression fracture. And I guess I would feel comfortable. Go on the holiday. Okay, but there's some caveats to that holiday. And I'm not going to repeat all of this. I'm just going to go down to here. So, remember this is a lifetime disease. So that patient needs to be followed. The bone density needs to be repeated. Medicare will cover a bone density every 2 years. So I like to get one at the end of the window of drug therapy and repeat it typically 2 years later. And of course, if she has a drop in bone density or a new fracture, that's the end of that holiday. Keep in mind, too, that we have no safety or efficacy data using alendronate past 10 years. So if the patient continues to be at high risk, you might consider switching the medication. Okay, now here's Nancy. She comes in, she's 70. She had a high trauma risk fracture when she was 48, but no low trauma fractures. She has severe reflux disease with a stricture, so she was not placed on an oral bisphosphonate. She actually got denosumab for her osteoporosis. Well, she's heard about this drug holiday, and she'd like one. So what can we tell her? And so these are some things that I would like to talk to you about. So keep in mind, denosumab is our as a monoclonal antibody. So we've got our osteoclast right here and expressing rank. And then the osteoblasts secrete rank ligand. This activates the osteoclast to break down bone. And denosumab is a monoclonal antibody that binds to the rank ligand and keeps it from activating the osteoclast. Really cool stuff. Well, so this drug was studied in the Freedom trial, and then we had some red flags appear in 2016. And these were just case reports and case series describing, these were patients who took denosumab during the clinical trial, the Freedom clinical trial at our medical center, and we continued to follow them in our clinical osteoporosis clinic, and they had multiple fractures after stopping denosumab. So a little bit of a red flag. This one was just horrific. So it was a case series of 9 women who had 50 spontaneous vertebral fractures after stopping denosumab. And if you look at the fine print, most of these women had a low risk of fracture. 6 of the 9 had a FRAX score less than 20. 6 had no prior compression fractures. 3 of the 9 had only gotten 2 doses of denosumab. And the fractures happened around 12 months after stopping the denosumab. So what's actually happening here is a rebound, dramatic increase in bone resorption once denosumab is out of the system. So what's happening to bone density? It's absolutely horrible too. So this was another report from about 38 women who were in the Freedom trial at that particular clinical center. Stopped denosumab, didn't take another osteoporosis drug, and had a bone density about 1.5 years later. And they lost all of their gains in hip bone density and 1/3 of the gains in their spine bone density. So the other thing that was really important is their bone resorption marker, C-telopeptide, was dramatically elevated. So again, this is a rebound increase in bone resorption, and this is just kind of a plot showing you bone breakdown. So here it's kind of low right after getting a last denosumab injection. Then the denosumab wears off and you get this humongous increase in bone breakdown, which is associated with that high rate of painful compression fracture. The idea is to give a bisphosphonate as the denosumab is wearing off so you keep that bone resorption or bone breakdown low. Now, there are clinical trials in progress right now testing alendronate, zoledronate, and raloxifene as a way to get a patient safely off denosumab. But we don't really know the results of those clinical trials and the timing of when we would start a bisphosphonate, and more importantly, how long to prescribe it. So what's the summary of this denosumab situation? After we stop denosumab, the patient has a dramatic increase in bone resorption or breakdown. The bone density plummets. Multiple fractures can happen even in people at low risk. And we can offer bisphosphonates as an exit strategy, but we don't have really great clinical trials data to know exactly how to do that. So we go back to Nancy. She wants a drug holiday. I would argue she should either continue denosumab or switch over to a bisphosphonate. So that's my little spiel about drug holidays, and I'd like to move on to glucocorticoid-induced osteoporosis, or GUP. So I'd like you to meet Wendy. She's a 28-year-old Caucasian woman who has lupus, and you can see the nice malar rash on her face. She is admitted for anasarca, and a renal biopsy confirms that she has lupus nephritis, and she gets pulse high-dose steroids, methylpred, 1 gram a day IV for 3 days. What do we need to do for her bone health, if anything? So there are guidelines that have been published to really help us sort out the complicated story of steroid-induced osteoporosis. And these are the just summary guidelines for older adults, and I'm going to focus on the younger adults since we're talking about Wendy. So the guidelines recommend for a young individual that we consider them at medium or high risk of fracture, from medium or high risk of steroid-induced osteoporosis if they already have a fragility fracture, if their bone density is more than 3 standard deviations below the normal range, if they've lost 10% or more of their bone density over a course of 1 year, or, relevant to Wendy, taking prednisone at these higher doses and a cumulative dose of 5 grams or more. And then don't worry about all of these first line, second line, whatever. The important thing is to think about this at the beginning of when you're starting glucocorticoid therapy so you can intervene and protect that person's skeleton. So going back to Wendy, she's going to get very high doses of steroids for multiple months, if not longer. So she is anticipated of having a prednisone exposure of 5 or more grams, and so she started a lendronate to protect her skeleton. She comes in 2 years later. Well, she did need prednisone for several months for the lupus nephritis, and also since then, intermittently, she's been taking it for flares. She's been on the alendronate and taking it faithfully for 2 years, but she's had a bone density drop despite that medication. Well, what can we do for her now? So I think this is a great chance to talk about the pathophysiology of steroid-induced osteoporosis. When we first start steroids, there's an upregulation of bone resorption, but the biggest problem with prednisone is it plummets bone formation. So it decreases the production of osteoblasts and it shortens their lifespan. So really the biggest problem with prednisone is low bone formation. And we have a drug that directly counteracts that. So teriparatide and now abaloparatide, which you might know as Forteo and Tymlos, they increase osteoblast lifespan and activity. So they might be wonderful drugs to use for our patients with steroid-induced osteoporosis. So this was proven in a clinical trial. They took adults on prednisone with low bone density, some of whom had fractures, and they were randomized to 3 years of teriparatide or alendronate. Everyone got calcium and vitamin D, and they looked at the endpoint of change in bone density of the spine. And you can see here that there was a dramatic increase in bone density at the spine and the hip with teriparatide compared to alendronate in the lower bars. And what was even more important was a difference in the rate of new vertebral fractures that was statistically significant and favored teriparatide. So Wendy is a great candidate for teriparatide. So I would like to go through some common misunderstandings about steroid-induced osteoporosis. And one of them is that prednisone must be taken for a long time to cause osteoporosis. Another is the same cut points, T-scores or FRAX scores, can be used to decide who should be treated for steroid-induced osteoporosis. And finally, the third myth is that once a person has taken prednisone, it's always a risk factor for osteoporosis. I'm going to go through some studies that show this. So this was a study that's very old now. It was a study of people with rheumatoid arthritis who were treated with gold. I don't even think we can get gold in this country anymore, nor would we probably want to even bother using it because it wasn't very effective. But these patients, were treated with gold for their rheumatoid arthritis, and half took placebo or prednisone, 10 milligrams daily for 12 weeks. So this is actually 20 weeks and 44 weeks. So they took the prednisone during this window, and then they stopped it. Look at that astounding drop in spine bone density in the 12 weeks of prednisone. Almost an 8% drop in the spine bone density. But then the good news is after they stopped the prednisone, they started to recover their bone density, almost back toward baseline. So, mythbuster. Effects of prednisone occur very quickly on bone. So think about it right when you start to prescribe that medicine for your patient. Don't think about it later when you may have missed the window of opportunity to protect that person's skeleton. Second, patients on steroids fracture at better or higher bone density or T-scores. This was a study done by von Sta using the United Kingdom General Practice Database, and what he did is he identified patients on steroids and compared the T-scores of the patients on steroids to the patients who were matched for age and gender and race, and then he looked at the rate of fracture based on T-score. So this is just randomly picking a lumbar spine T-score of minus 2.5. And in this group of patients, you can see only 4% had a clinical fracture in the control group, almost 20% of the patients on steroids. So you see that even at a T-score of minus 1, the steroid users have a much higher risk of breaking a bone. See, it's like about 12% compared to the controls. So just keep that in mind. And this is the mythbuster. The same T-score or FRAX score cannot be used to decide who should take treatment to prevent osteoporosis, as you would decide for somebody not on prednisone. Okay. Then the third mythbuster is that idea that ever use of prednisone forever and a day increases the risk of breaking a bone. Again, this was a study by von Sta, who's really done the best work in this field. And it looked at the relative risk of fracture from the time prednisone was stopped, that's time 0, until several years after the steroids were stopped. And you can see that shortly after stopping, the relative risk is about 50% higher, but it comes down to almost 1.0, and certainly the confidence intervals include 1 5 years after the patient stopped steroids. So this is epidemiologic data, but it really suggests that when a patient stops steroids, they have some recovery of their osteoblast activity. They can form bone again. And the mythbuster is that ever use of steroids is not, in my mind, a lifetime risk factor for fragility fracture. So keep that in mind, because when you get a FRAX score at the UW or the VA, the technician is going to enter yes if the patient has ever taken steroids. And you may be sitting in that clinic room and saying, this patient only took prednisone, 5 years ago for PMR and is not long off of it. And if you recalculate that FRAX score, that may make all the difference between whether you decide to treat that patient or not. Okay, so just summarizing, prednisone has very rapid effects on bone health. Patients on prednisone fracture at higher bone density, so the same thresholds cannot be used to decide who to treat. And off prednisone, there is some osteoblast recovery and bone density increases and fracture risk falls. Okay, we're doing perfectly for time. Okay, so there'll be plenty of time for questions. Okay, so then I'd like to talk about the patient on dialysis. So keep in mind that you have a dialysis patient who fractures. that patient has renal osteodystrophy and not osteoporosis. So I'd like you to meet a patient of mine. Her name is Sharon. She's a 51-year-old Caucasian woman who developed lupus nephritis and was treated with prednisone and cyclophosphamide. And despite that, she progressed to end-stage renal disease, and she was on dialysis. Then she developed tertiary hyperparathyroidism, had a subtotal parathyroidectomy, and was considered a surgical cure with a PTH now within the National Kidney Foundation range for health in dialysis. So past medical history, pretty typical for a patient who's on dialysis. High blood pressure, high lipids, gout, colitis, obesity. She's on a number of medicines, but not taking calcium or vitamin D. And in fact, her dietary calcium intake is very low. She fell and she broke her wrist. And so this prompted a bone density, and she had an increase in her spine and hip bone density, but a dramatic drop in her forearm bone density. Luckily, she had no compression fractures on her vertebral fracture assessment, but at that time she was found to have hypercalcemia, and she stopped all of her vitamin D and calcium supplements, and her calcium remained high. So I'm going to just highlight that her PTH is low, her calcium corrected for albumin is about 10.5, phosphorus is high, her vitamin D level is actually kind of on the lower side, and her bone-specific alkaline phosphatase is normal. So I'm going to have you think about just commit in your mind to what you think the diagnosis is. I hope I've interested some people in the room about this case. So the National Kidney Foundation has set out some very nice guidelines for the diagnosis and management of renal osteodystrophy. The new term for it is chronic kidney disease, mineral and bone disorder. Please forgive me, I am going to say renal osteodystrophy because it's easier for me to spit out those words. So renal osteodystrophy. So if we look at patients who are on dialysis who break a bone or who have low bone density, they basically all have a form of renal osteodystrophy. And absolutely none of them have osteoporosis on a bone biopsy. So this is a figure out of the National Kidney Foundation review article. And osteitis fibrosis cystica, which is hyperparathyroid bone disease, is actually the most common form that you'll see. Adynamic bone disease in this particular article was about 20%, but more recently we think it's more and more likely. And this is a condition where bone formation or bone turnover is very low. So you do a bone biopsy and you see few osteoclasts, few osteoblasts, and they're not metabolically active. Osteomalacia, which we also know as adult rickets. So the bone is forming, but it's not mineralizing, so there's not enough calcium and phosphorus coming into the bone. And a mixed picture, which is a combination of osteomalacia and a hyperparathyroidism. Just look, only 2% of these patients have a normal bone biopsy. So this is a challenging set of diseases to diagnose and manage. But I just want to point out that it's a big problem. If we look at the patients on dialysis, their chance of having a hip fracture is fully 4-fold higher than patients who don't have chronic kidney disease. So we are going to see these patients who have a fracture and they're on dialysis. And we need to recognize what we're dealing with and figure out how to treat it. So you can get a sense of what you're dealing with based on labs, and sometimes imaging will help you. So for hyperparathyroid bone disease, the parathyroid hormone is very high. You might be lucky enough to see a Rugger Jersey spine or brown tumors in the spine. If you have the other end of the spectrum, which is adynamic bone disease, that's low bone turnover, the PTH is very low, or less than 2 times the upper limit. There's really nothing specific on x-rays. Osteomalacia, that's characterized by a high bone-specific alk phos, and if you're really lucky, you might see a perpendicular crack in one of the bones of the skeleton. That's a tiny microfracture, and it's usually on the inner cortex, so inner humerus or inner femur. A mix of the two, hyperparathyroid and osteomalacia, so high PTH and high bone-specific alkaline phosphatase. So how well do these labs work? So this was a wonderful paper that was published within the past couple years, and it was basically done in a group of almost 500 patients who were on dialysis and had a bone biopsy, and then they had stored serum. And so they took all this stored serum and sent it to one reference lab, and they measured intact PTH, whole PTH, which is looking at just the fragment that's biologically active, and then they also looked at bone-specific alkaline phosphatase. And of those three labs, intact PTH actually performed the best. But look at how low we have for sensitivity and specificity. So if the PTH is low, suggesting adynamic bone disease, it was only 66% sensitive in properly identifying somebody who had adynamic bone disease on their bone biopsy. And likewise, for high bone turnover with a high PTH, you're dealing with hyperparathyroidism or osteomalacia, only about 40% sensitivity to properly identify that patient. So the guidelines say, do check the intact PTH, check the bone-specific alkaline phosphatase, because markedly high or low levels can help point you in the right direction diagnostically. They recommend against other bone turnover markers because either they just accumulate because of the renal failure or they haven't been validated. And then, I hope this isn't a sign that something's going to crack. Okay, so if those tests don't point us in the right direction, then perform a bone biopsy. So, who would we do a bone biopsy on? Somebody who has dialysis and unexplained fractures, persistent hypercalcemia, suspected osteomalacia, treated for hyperparathyroid bone disease but doesn't respond properly, or a drop in bone density or a new fracture despite treatment. So going back to Sharon, I'm going to pick on you guys to see if you can tell me what you think she has. So she's on dialysis, she broke her wrist, her calcium is high, her PTH is low. Anyone want to shout out what she has? Thank you, Dr. McCowan, adynamic bone disease. Yes, so you are right. So we did a bone biopsy on her. So the bone biopsy showed adynamic bone. There were few osteoclasts, few osteoblasts. So what do we do for this patient now? No FDA-approved therapies. So this is my slide that doesn't, it's violating the statement because teriparatide isn't FDA-approved for adynamic bone. Basically, if you have somebody with adynamic bone, you try to withdraw anything that's suppressing bone turnover. So we would stop calcium and vitamin D, try to make the parathyroid hormone levels rise and increase bone breakdown. Avoid drugs that reduce bone resorption, so bisphosphonates, denosumab, vitamin D analogs, these would all be harmful to this particular patient. And then avoid drugs that drop bone formation like prednisone or heparin. Now, there are case series describing teriparatide as a way to treat adynamic bone because it increases bone formation and resorption, and these case series have reported higher bone density too. So this is going back to Sharon, and I just want to walk you through her calcium levels. So this is where she had her subtotal parathyroidectomy, and she had a drop in calcium, but then several pretty high levels. We did the bone biopsy, and then here we started teriparatide, and you can see that overall her calcium levels are falling very nicely. And so did her phosphorus. So what's happening here is that we are stimulating the bone turnover, and she could actually use her skeleton to sink extra calcium into the bone. So keep in mind that the skeleton is a reservoir for calcium and phosphorus, and when it's inert, it can't accept excess calcium. We increase bone turnover. Now the skeleton can accept calcium into the bone. So we stopped the teriparatide, calcium went up again, and we restarted it, and the calcium came down again. Very nice example of the pathophysiology of adynamic bone disease and a potential way to treat it. And this is kind of interesting because teriparatide normally can cause high calcium in somebody with osteoporosis, but in this case, the patient's calcium came down into the normal range because we stimulated bone turnover. Who does bone biopsies at UW? I do. So, and they take a while to accomplish. So keep in mind, if you send in a consult, it takes a while. We have to get the consent. We have to pick the operating room date. We have to label the bone with tetracycline to look at bone formation. So it really takes a good month after I see the patient to actually get the bone biopsy done. But, if you have a patient that you think needs a bone biopsy, send me a note in Epic, and I will work the patient into clinic and help that patient out. Okay, so going to go through the learning objectives, and then I'd like questions at the end. So we talked about the limitations of FRAX. The first limitation is it gives you potentially conflicting recommendations. Treat osteoporosis in Laverne, treat if the FRAX score is 20% or higher. Well, the FRAX score might be lower than that. Doesn't count falls and doesn't count the number of fractures. Includes prednisone use if ever used, which I think is not really accurate. And it's not validated for use while on an osteoporosis medication. Who are some patients who are potential candidates for osteoporosis drug holidays? So a holiday might be considered in somebody who doesn't have osteoporosis by T-score, hasn't had a spine or hip fracture, not taking prednisone or having an active condition that would cause osteoporosis, and is not falling often. I would argue that we wouldn't want to necessarily give a drug holiday if somebody's already or still has osteoporosis, has had a prior fracture, falls often, still taking prednisone or having another active condition that would cause osteoporosis, or most importantly, if they're using denosumab, that is not a person you want a drug holiday on. Recall the differences between glucocorticoid-induced osteoporosis and age-related osteoporosis. The first and most important is there are different thresholds that would prompt onset of therapy. So patients are breaking bones at better bone density, higher T-scores, lower FRAX scores. Keep in mind that prednisone rapidly harms bone at any age, so please consider protecting the skeleton even in your young patients like Wendy, because she can have a dramatic effect on her bones just in the short term. Also remember, when we stop prednisone, the bone density can increase and the fracture risk also then falls. And finally, the most important thing to remember about renal osteodystrophy, if somebody is on dialysis and breaks a bone, they have renal osteodystrophy. It's pretty unlikely that they have osteoporosis. And these are the forms of renal osteodystrophy, hyperparathyroidism and adynamic bone. And you might be able to diagnose either one by checking the PTH and bone-specific alkaline phosphatase. If you need help and need a bone biopsy, just send me a note. And that's the end. And I know that was a whirlwind of cornucopia things, but I'll take questions. Okay. There's a question in the back. Okay, so that's 3 questions, but I will. The first question was, what should we do about dental health in the setting of osteoporosis drugs? So the bottom line is that the risk of osteonecrosis of the jaw is actually very low in the osteoporosis clinical trials. You'll see it much more often in the oncology patients who are getting bisphosphonates IV, say, every 3 months for myeloma or prostate cancer. But in the osteoporosis world, the risk of jaw necrosis is somewhere around 1 per 10,000 patients exposed for 1 year of a bisphosphonate. Similar or maybe a little bit lower numbers with denosumab. Your second question is, why should we even use denosumab? I mean, there are patients who can't take bisphosphonates. Let's say you're convinced that they have osteoporosis, but their GFR is below the threshold, and those are patients I have on denosumab. I just think we have to be very clear. Don't miss a dose of denosumab. Don't stop the drug. Sometimes that raloxifene has its own problems, and one of them is that we really don't have data that it reduces hip fracture. So if you have somebody who has pretty severe osteoporosis, you might really think raloxifene is not all that effective for that patient. And then your third question is about calcium and vitamin D. So I don't know how many meta-analyses have now been conducted on calcium and vitamin D. The bottom line is that they, in and of themselves, are important for nutritional health, but really they're not considered an adequate intervention once somebody has osteoporosis. And so all the clinical trials of osteoporosis drugs would just give everybody calcium and vitamin D, and then they randomize to the drug or placebo and compare the effects. So we want somebody to have adequate calcium, we want them to have adequate vitamin D, but I would not consider that a sufficient treatment for osteoporosis by itself. Dr. Mackey. So why would I pick alendronate versus zoledronic acid? What are the differences? So alendronate is really considered first-line therapy. Pretty much all insurance plans would like you to start with that drug, and the VA included. The GI side effects are potentially a problem. So I wouldn't want to give somebody alendronate if they have esophageal dysmotility, or they've recently had an ulcer in their esophagus or stomach, or if they've had a stricture. I would really want to avoid alendronate and prefer to give zoledronic acid. I also haven't been able to get zoledronic acid for patients who are poorly compliant to alendronate, so they've been given it and they're just not able to take the weekly dose, and I've been able to get zoledronic acid approved in that scenario. The nice thing about zoledronic acid is its wonderful adherence. I mean, literally I describe it as the McDonald's drive-through treatment for osteoporosis. You go in, you get your 15-minute infusion, and you're done for a year. So, but it's much more expensive, and so the insurance plans kind of like us to try the oral bisphosphonates, and if we have a contraindication, I've been able to get zoledronic acid covered. Question there? Oh, the second question. Why do we even use FRAX? Because it's better than nothing. Why isn't it fixed? The guy who developed it is kind of in semi-retirement now, and and it's a proprietary trademark equation. So it's not a publicly available set of equations that we can all go in and modify ourselves. But it needs to be fixed. I totally agree with you. Question up here. Okay, good. Yeah, that's a great question. So the question was, bisphosphonates have a long half-life in bone. What's the shortest amount that we can use them and still have protection from fracture after stopping? So it looks like it's about 5 years. There was just a paper that was a study that was released at the bone meeting in Montreal in October, and it was a analysis of Medicare patients by Jeff Curtis, who works at University of Alabama. And it looks like the patients who only took bisphosphonates for alendronate for 3 years and then started drug holiday didn't have protection from fracture compared to people who have taken it for 5 years or longer. Yeah. Molly. Thank you, Molly. That's a tough question. So your question was, women are breastfeeding longer, and what does that do to their bone? I feel like I need to go and check the literature on that one, Dr. Carnes. What I do know is that during the breastfeeding period, and actually during pregnancy and the breastfeeding period, there's an increase in bone turnover to support the skeleton of the child, the fetus and the baby. What I've seen then is that there are drops in bone density, but they recover after pregnancy and breastfeeding. That's what I've seen, but I haven't seen the data divided in the way that you're asking, meaning if somebody breastfeeds for like 3 or 4 years, do they recover the same as somebody who might breastfeed for only 6 months? I don't know. I'm sorry. Yes, question in the back. Yes. Can you say that? You're saying, why would you not? Uh-huh. Right, right. Mm-hmm. It could be a reason to restart, absolutely. Well, it's kind of the difference between group statistics and an individual patient. I mean, I feel like it's kind of like saying, well, in the whole group of people who have high blood pressure, maybe you're not preventing that many strokes, but when you have a patient in front of you who's having a drop in bone density that's significant, and you know that person has osteoporosis or is at risk and has been at risk in the past, that is a compelling reason to restart. And keep in mind that when you take postmenopausal women as a group, 1 in 2 of them have a fracture in their remaining life, and for men, 1 in 5. So it's not as if you can just take that data and say, I'm not going to check your bone density for 5 years. I really think it's important, if you still have somebody who's in your clinic and being followed for osteoporosis, that you need to intervene before, if you see a drop, that's a sign that they're going to be at higher risk of fracture. Now, how much of a drop? That is an individual decision. I mean, I don't think I can give you like a specific formula, how much do you want to see it drop. I do use FRAX scores. So let's say a patient has had, we do calculate a FRAX score if the patient has been off an osteoporosis drug for at least 2 years. So when you get your bone density reports at the UW, you should be getting a FRAX score if that patient has been off therapy. And that, I think, will help you too. So you might see the bone density drop, but yeah, the FRAX score is still only 15%. Maybe that person doesn't need to be back on treatment. But bone density drop and FRAX score is now 28%. That's a different story. Does that answer your question okay? Okay. Dr. Mackey. So there really isn't good validation that we can use the FRAX score while somebody's on therapy. There's one study by William Leslie out of Toronto, that suggested maybe it worked okay, but there's not been universal agreement that it's okay. I will sometimes still calculate it though, because we might have a scenario where the patient was started on a drug for osteoporosis and they want to stop, and let's say their FRAX score, even if they've never been treated, was only 15%, I would still argue that that's useful information. But it's when you refer somebody for a bone density and they're on therapy, we just won't calculate a FRAX for you because of that whole issue of whether it's a valid tool in that setting.
Thank you very much.
Thank you.
I just want to say, this is a great example of a very sophisticated grand rounds. It seems so practical, but that's because you know the data and the literature. So thank you for making this very exceptional.